Good morning, and welcome to this edition of Medical Minutes. This morning, I have the pleasure of introducing Dr. John Dailey, an ENT specialist. For those of you who don't know, ENT stands for ear, nose, and throat. Dr. Dailey has practiced here at Passavant Hospital since 1978 and has a rather extensive experience in the field of ENT. Today, we'll be talking about common pediatric ENT pathology, mainly chronic ear infections in children and chronic upper respiratory infections, specifically with reference to their tonsils and adenoids. Dr. Dailey is a board-certified otolaryngologist and a member of the American Academy of Otolaryngology and Head and Neck Surgery. As I stated earlier, Dr. Dailey has been on the active medical staff since 1978, and he presently holds the position of Chairman, Department of Surgery. As always, I'm your host and moderator, Dr. Peter Russotto. Welcome, Dr. Dailey.
Thank you.
Our first question, Dr. Dailey. I would like for you to tell our listening audience about the problems children can have concerning hearing loss and recurrent ear infections, sometimes associated with chronic sore throats and/or tonsillitis.
Well, first of all, hearing loss occurs in two different types. We sometimes see children who have hearing loss due to nerve deafness, which is much less common than the more frequent type of hearing loss in children, which is called a conductive hearing loss. And that's associated oftentimes with recurrent upper respiratory infections, colds, tonsillitis, sore throat, and so forth. The reason for that is the swelling that occurs in the back of the throat with tonsillitis causes a blockage in what's called the eustachian tube, which is the tube that connects the throat to the ear, that is specifically to the middle ear. That in turn causes a correct collection of fluid behind the eardrum, which then can be a cause of hearing loss. Many times this is an acute or sudden type of problem that occurs and is oftentimes the reason for children complaining of ear pain and so forth, which oftentimes causes them to be taken to the family doctor or to the emergency room to be treated for the sudden onset of pain and discomfort. Many times I see the patients after they've been treated because they come in due to persistence of the fluid behind the eardrum causing the hearing loss.
In a real young child, like a baby, I'm sure sometimes the mothers might notice the child tugging on the ear or irritability. Is that something that they should look for?
That's a symptom that may suggest that the child has an ear problem, although in children who are beginning to cut teeth or have their teeth are coming in, that may also be a reflection of pain in the ear from the new teeth that are coming in.
When a child does come in for evaluation, other than, of course, a good physical exam, what are some of the other tests that you might provide or perform to definitively tell whether they have a hearing loss?
Well, the first, of course, thing that's done is to examine the child and try to get an idea of what the eardrum looks like. Sometimes you can tell if they have fluid, many times you can't. And this is one of the problems that we encounter where children have been diagnosed as having recurring ear infections and or persistent fluid, when in fact oftentimes you can't tell unless it's an acute problem. So once we see the child and try to make a determination whether there's fluid behind the eardrum or whether they're suffering from a hearing loss, the next step is to do a hearing test. There are two types of tests we do. One is just a plain audiogram or hearing test. The other type of test is called a tympanogram. The first test tells us if the child can respond to what are called pure tones and or to word testing. The second test actually measures the movement of the eardrum in response to change in pressure in the ear canal. Both tests are very helpful. In very young children, the tympanogram is the important test because that's an objective study, whereas the actual audiogram pretty much depends on getting a response from the child, and you see that more commonly in older children, or you can test older children easier than very young children. There's another test in which we can test children at a very young age, the otoacoustic emission test. which again is an objective study that's often done on newborns, but we also use it in the office in young children if there's any question whether they're hearing or not.
Just to put the listening audience, the mothers at ease, I'm sure all these tests are rather painless, so to speak.
Yes, very painless.
What would be the actual treatment, though, then say you discover maybe chronic hearing loss because of chronic sore throat or tonsillitis or the eustachian tube being blocked? What are some of the treatment options available?
Depending on how much hearing loss the child has and how often they've been treated for recurrent infections, obviously the first line of treatment is to treat the acute infection, and many times that will result in the problem being resolved. If they continue to have recurring infections and hearing loss, then the next step is to suggest a procedure called a myringotomy, where we make an incision in the eardrum under anesthesia to remove the fluid and insert a plastic tube called a ventilation tube. Also, in children who have an associated tonsillitis or recurrent adenoid infections, in older children, one might consider also taking out the tonsils and adenoids, although that's usually not the first line of treatment.
You know, you talked briefly a little bit about the insertion of the ear tubes. Are these put in during an office procedure, or is it a same-day surgical procedure or an ambulatory surgical procedure?
No, this is only done under anesthesia in children.
Well, what can the mothers expect from their children right afterwards? I mean, is it relatively painless or?
Yes, the procedure, when it's done under anesthesia as an outpatient, usually at the hospital, results in most cases with the child being able to hear again and a decrease in the frequency of the recurring ear infections. There's no pain associated with the procedure afterwards. The only caution that we recommend is that the child needs to be able to keep water out of his ears for fear that the water may carry some bacteria into the middle ear, where the tube acts as a conduit, and therefore we also recommend that the child wear earplugs if they're going to go swimming or if they're taking a bath.
It is my understanding then that really these little tubes basically fall out with maturity. They don't have to usually require another surgical procedure. Is that correct?
That's correct. Most of the time the tubes will come out spontaneously. Depending on the type of tube that's inserted, they may stay in for an extended period of time, but that's unusual.
And then once the tube does come out, I'm sure you have to physically examine to make sure the eardrum heals together, correct?
Well, normally what we recommend is that once the child has vent tubes inserted, that we follow up with them intermittently every few months to check to see if the tube is still functioning and then to see if the tube has come out. One of the unusual but occasional, I guess it'd be better to say an occasional side effect from putting tubes in is that when the tube does come out, the patient has a persistent opening in the eardrum. And that's something that may have to be treated surgically at some later time, if it doesn't heal by itself.
I'm sure, too, as the child becomes a little bit older in the pediatric population, is it common or uncommon that sometimes the child might have to have a second insertion of this ventilation tube?
Depending on the age of the child when the tubes are inserted, the average child usually does not have to have recurrent or tubes reinserted, although there is about a 25 to 30% chance that may be necessary.
Are there any other alternatives to the ventilation tube?
Not really. If you have persistent fluid behind the eardrum, in a young child, that's about the only option. Now, in older children, there is a medical type of therapy you can recommend, and that is where the child starts to or is able to blow up balloons, forcing air up through the eustachian tube. My experience has been that probably doesn't do much in a youngster who has persistent fluid, but it's something that is worth trying, and once in a while that will result in a resolution of the fluid, and so you can avoid putting the vent tube in.
Concerning ear tubes, you've been in practice since 1978. Has this been a fairly new procedure, or is it something that's been done for 30, 40 years?
Well, actually, the procedure has been around for a long time. It was popularized probably back in the 1960s by a ear, nose, and throat doctor in Charlotte, North Carolina. His name was Beverly Armstrong. And one of the tubes that we frequently use now is the Armstrong tube. Since that time, of course, the types of tubes that have been developed have been quite unique, and some of them have worked better than others. And you use different tubes for different types of situations. For example, if you have a child who has to have a second set of vent tubes, we often try to put a tube in that may have a longer lifespan, that is, has a larger flange, so that you don't have to keep going back and keep putting tubes in. The object is that you hope that as the child grows and as his ear develops, that the eustachian tube will, in fact, mature to the point where it functions properly and you no longer have to worry about recurrent fluid.
Are there very many side effects for this procedure? I would think it's relatively safe, because sometimes I see your name on the schedule. You're putting in 5 to 6 in a day.
No, the main concern is that the patients need to have after surgery, keep the ears dry so that they don't get water in the ears. Sometimes they can still get an infection even with the tubes in. The difference is that usually the ears will start draining, so we always advise the parents that if they notice drainage from the ears, that they should contact us. Usually you treat that with antibiotic ear drops. Once in a while you may use an oral antibiotic. Most of the time it responds very well to treatment.
Very favorably with low side effects is what the general population really looks for.
That's correct, yes.
Well, that was very good information, Dr. Dailey. Is there anything else you wanted just to offer the listening audience about pediatric ENT?
Well, there are a lot of other considerations. We didn't really get into the idea of, or the subject of tonsils and adenoids in relation to the tubes. As I said, that normally in younger children, that's not a consideration, but as the child grows, for example, in children in the range of 4 to 6 or 7 who have recurring ear infections and have to have repeat tubes, many times taking out the adenoids and or the tonsils is helpful. And again, the whole purpose of this is to help the eustachian tube function better.
Well, thank you very much for coming, Dr. Dailey. Fantastic information there, and we'll probably have another broadcast with other ENT, but I want to thank the listening audience for tuning in, and good health.